right, so I think we're going to actually get started here. We're 3 o'clock, and I'm just going to share my screen, and we're going to get going. Okay. So in essence, I'd like to thank you guys all for being here, ladies and gentlemen, for joining us today for our AIC education series, basically the free webinar series called AIC Shorts. So actually, one of my my front staff, Karen Young, has had some sessions with you guys, I believe, as well, on case acceptance, and should be talking about a few other things, which I'll, coming up. So they have a really nice lineup as well. But I'm glad that you were able to join us for today, which I believe I'm very passionate about this topic, sinus lifting, because it was one of my Achilles heels. Other than connective tissue grafting, I was just, terrified of the sinus, and I think most of us are. There's so many cases that we see that we're not treating just because of that. And I think once you are able to understand this presentation and the kit, which is extremely very easy to use, it'll open up your realm as far as being able to treat a lot of different patients that you may not have been able to treat before. So a little bit about myself. I graduated in 2003. I have a GP practice where I focus on perio and implant surgery. Most of my expertise is in immediate implant therapy, and I've done close to 4,000 plus immediate implants. So those are, I've done probably close to 500 indirect sinus lifts with the CAS-kit in particular, and had the opportunity of spending some time with Dr. Cho, who invented the kit, who's done thousands of those lifts. I'm also the course director and clinical instructor for the master or the basic implant training program that Hiossen runs in the Greater Toronto area. And most importantly, I'm also the founder of the Ontario Dental Implant Network. I know we have some members here today where we provide live surgery and just mentorship. We have a chat group, these types of things. So this is a little bit about our club. We've got 60 members now. You can check out the website. And currently I'm offering just doctors to come into our group chat, just, because of the COVID situation, to help out at no charge, just for maybe a month or two, just to, be part of our program until our newest starts. So you will be receiving category 1, sorry, let me just move my column here. So you'll be receiving category 3 points, and it'll be 1 point AGD. There are going to be some verification codes. So I just want to make sure that everybody is aware of that, and there will be 3 throughout the program today. So we just want you to note those. So the first one is going to be Vancouver. Okay, so we'll have a verification code in the middle of the presentation. We'll have one at the end of the presentation, and all 3 will be required to qualify for the points. Okay, and Hiossen or AIC will issue those. So, this course actually is a full evening course. We do hands-on, which obviously we can't do today. It's about a 2.5 hour program. So I'm going to try to condense everything today in about 45 minutes. Okay, so I don't want to go too much into detail with anatomy, but in essence, we just need to be aware that there are sinuses, which are big spaces in our head. The one we're talking about today is the maxillary sinus, but there's frontal, ethmoid, and sphenoid sinuses as well. The maxillary sinus happens to be one of the largest of the paranasal sinuses, and they can be very large. The average volume actually is around 15, even more cc's. So, a lot of people say when we add bone grafting, how much can we add? It's a very large space, and it takes a lot of bone to plug the ostium, for example, right, which is the drainage to the sinus. So it's located in the maxillary molar region, although it depends on the classification or category. Some of these areas can come, some of the sinuses can come fairly far anterior, all the way up to the distal of the canine. Okay, so you got to be mindful of that. There's different walls. So I think the most important wall, of course, is the inferior wall, where how much residual ridge height do we have, but also the medial wall. Because we do want to try to elevate the sinus on the medial wall as well when we're doing sinus lifting. Especially when we're doing lateral sinus lifting, we want to really make sure we hit that. The lateral wall is one that we're very concerned about when we're doing lateral sinus lifting. And the anterior wall, again, is really important to be able to access when we're doing proper sinus lifting, depending on the area. So the inferior wall, obviously, depending on the position and the pneumatization of the sinus, that will leave a certain amount of residual bone. There can also be septum, right? So those are additional projections. I love those. Because those are areas where we can engage our implant, in bone, right? Because that's additional bone, and normally it's cortical bone. So the inferior wall can be positioned different ways. Oftentimes we'll see, you look at a CT scan, how many times have you done that? And then you see that basically, the measurement says 5, and by the time you actually get to that area, it's about 7. And it's normally because we have a type 1 type of situation where the sinus kind of is further, I guess you could say coronal, or drops down towards the buccal. And normally we're placing our implant further palatal, so you have more bone in that area. So don't be surprised that you're going to have more. Depends on where you're placing your implant, right? The sinus membrane, obviously, that's something, the Schneiderian membrane, we don't want to perforate because these can lead to complications. So this is one thing where the CAS-kit really comes into play. It's a very safe system. It's nasal mucosa. It's similar to nasal mucosa, although I find, because I do nasal lifting in my office as well, that it's not as robust or thick. Again, it depends on the patient. If they're smokers, you often find that there will be a thicker membrane, which makes it easier to lift. When you see mucositis on these, and then again, that will be an indication that it'll be easier to lift. When you start seeing sinusitis or opacities or different types of pathology, then these are things that we have to be concerned with. Okay, so you have to plan your surgery accordingly. So the history, just very quickly, is just Dr. Tatum obviously first reported on lateral sinus lifting, in particular the lateral wall, and then shortly thereafter the crestal approach. Dr. Summers had come out with another technique using again an indirect approach, which many of us, when we early on in our careers, started using, and those were with osteotomes, which we still use. And these osteotomes can be used to compress bone, but more importantly, they can be used to infracture the bone and then lift the sinus. And the goal is hopefully to bring that piece of bone that you've been fractured with the membrane. Again, when we have resorption, depending on the length of our implant, we would need to accommodate that volume of bone that needs to surround the implant. So in my practice, I typically consider I would even say a 10 millimeter implant, a standard size implant. So generally, most of my cases, my goal is to place a 10 millimeter implant, although they do make 7 and 8. But again, think about it. Do you really want a 6 or a 7 millimeter implant in, very soft bone under heavy load, right? Because again, we're talking occlusion wise, more force at the back. So I prefer, again, 10 millimeter. So this is what we want to do. We want to achieve room or space for a 10 millimeter ideally. So the characterization generally in the maxillary posterior area is that the bone is softer, right? So when we treatment plan, we deal with these areas, we have to come up with a different approach, whether it's going to be compression, using osteotomes or densiburs, which we'll talk about briefly, under drilling, right? We always talk about under prepping when we have D3 or D4 softer bone. I'm using rough surface or tapered implants, which, as you start placing them, they get tighter because they're relying on the crest for stability. So how do we overcome these types of issues? Typically, we're using different approaches to manipulate the sinus or avoid the sinus, right? So lateral, crestal, short implants, or just completely avoid them by using zygomatic or engaging the lateral wall of the nose, which we'll do at times. So are you intimidated by sinus lifting is the question, and I'm assuming many of you are. Can we see hands? I can't see your hand, but I'm assuming I can see a lot of hands out there. This is why you're here. So I was of the same mentality, and I think today hopefully is going to really help clarify and help. But I do want you to be aware that both crestal approach and Hiossen, actually, again, one of the leaders, I believe, in the industry of just ingenuity when it comes to making things easier, has developed the crestal approach kit, but also has developed a lateral approach kit. And these are all what we're going to talk about today, in particular the crestal. They all are very safe. They're all the drills are non-end cutting. Everything is planned methodically. And again, everything has stoppers on it, just like the regular taper kit for those of you who are used to that. Again, many of you love that because it has a stopper system. So of course, the crestal approach, the difficulty is access, right? We can't see, but the procedure is much easier, the recovery much quicker. We can use these when you're first starting out, I would say have at least 7 millimeters of bone, but I've done cases with 1.5 millimeters of bone. With residual bone, and this comes with more experience, of course. Or what if there's an artery? I'm going to show you a case where there was actually an artery and a concern when we were going to do lateral sinus lifting that we would have bleeding issues, and the patient's medical also was not conducive to a large surgery. So this is where a crestal approach can really help out. Of course, a larger approach gives you access, but again, there is, in my opinion, a higher risk of tearing. Now, of course, if there is a tear, it's much easier to correct when we're going a lateral approach. So I think once they start getting into more, sinus surgery, you do have to be comfortable with a lateral approach. You need to be able to, but again, I don't feel like it's required to be able to treat that area, because those should happen few and far between if you use the technique properly. And what our goal here is, and hopefully you guys can see this video okay, is a lateral approach is great, right? You can see these are some immediate implants that I placed in areas, and we did a lateral sinus lift as well. And it's really cool, and the video is awesome, but I can tell you, it's a large site, the patient hurts a lot, and at the end of the day, it's not, if you can avoid these traumatic surgeries, then why go for it? So you'll notice here, this is a case that I recently treated probably several months ago, and you'll see there that there's actually the artery from the posterior superior alveolar branch. And these arteries, when we're doing lateral sinus lifting, it causes a lot of bleeding. Visual access is extremely difficult. So why not use a crestal approach? You'll see here this patient had that same concern. Dr. Sheikh, there's only 1 or 2 millimeters of bone here. What can we do? Well, the great thing with a crestal approach in the Hiossen kit is that we can use hydraulic pressure. And look at this. This patient was so concerned that mid-treatment, I actually took a CT for her. And I said, let's just check this to make sure that we've lifted it and we've added enough bone. And I actually gained 10 millimeters of volume here so that I could actually place a 10 millimeter implant. And this was all done through the crest, right? And it's possible, it's predictable, okay, as long as you follow the steps. And I think this is important to say. So we all know about the osteotome approach and how hard you tap. And again, I call it the old school approach. The problem with this technique was very difficult to learn that green strip, how hard you tap. Right? And again, then there's a risk of perforation. You don't have access. And try doing this in a 7 region or even some 6s where there's been some resorption of the ridge and you can't see over the tooth. It's extremely easy. And if it's not easy, it's like my intro camera. If it's not easy for me to use, or my laser, if it's not easy for me to use, I'm not going to use it. So, and it also leads to a negative patient experience, right? So DENSA burrs are also out there, being by Versa, great tools to use. Okay, the issue with these burrs is that I've had multiple perforations and I've used it according to their protocol. So I feel like there's a bit of a higher risk here. You can see the tip of the drill. What it does is it expands and it pushes the bone, but I've seen colleagues, including myself, who have perforated. And the beauty of the CAS-kit is we're using hydraulic pressure, which is water, which in my opinion is much safer. So the other problem with the DENSA is there's a cost factor, right? Each drill is very expensive. You get a limited number of uses, and their indications on their own platforms and their own instructions of use state that really once you start getting down to smaller residual ridge cases, you really should just be grafting, or maybe not doing an immediate implant, or even not using the drill. What's nice about these drills is they're good for immediate molar cases, okay, where we can't get a hydraulic seal. So frustration occurs, right? There's frustration. This is how you feel when you want to treat a case,
stuck in a basement, sitting on a tricycle, girl getting on my nerves. Going out of my mind, I thought she was fine, don't know if her body is hers.
So, we're all getting frustrated. What do we do for these patients? We're having perforation. So what, I don't want to treat these cases. I want to refer them out, right? Well, welcome to the CAS-kit. Okay, I've been using it for God knows when, since it came out, at least 6 years. And it is a kit that is safe, and again, will lead to minimal risk of perforation. Of course, we don't say no risk, there's always risk, but typically those perforations occur due to operator error. And I'll go through some of those things, but generally there's 3 steps to this, okay? The first step is using drills in a certain way with stoppers, okay? So non-end cutting drills. The second is then using a hydraulic lifter, which is again, sterile saline. And the third is then bone grafting prior to implant placement. And we'll talk about bone, do we need bone? So the first feature is that the drills themselves are optimized with a round shape and an inverted cone such that as they're drilling, as you're using them, and again, you're going by 1 millimeter increments, okay? It creates something called a bone lid, and that bone lid stays attached to the membrane, okay? And what happens is, again, you don't get that cut. That drill typically doesn't really touch the membrane anyways, because you have that bone lid. The drills, I'll talk about the speeds, are generally used at a lower speed. The second feature would be the hydraulic lifter, which fits in nicely into that osteotomy site that you've created. And again, what we're doing is we're using sterile saline in a in and out motion, again, gently, to slowly, but diffusely lift the membrane. And then the third portion, and I love the new design that they've had over the last couple of years, which is a bone well. They've just been able to, a bone carrier, which can actually charge the unit and then basically just kind of continue to pack bone very quickly, very effectively, and very efficiently, as opposed to their older system, which had a condenser. So it's safe, it's very safe, it's very easy to do. So part of our basic implant training program, actually, we used to have doctors who would be doing this as part of their basic implant training. Obviously, our CDSO had removed that. So we're no longer doing that. We haven't been doing that for years, but I feel like it is a basic procedure and most basic doctors should feel comfortable doing it. And what's great about Hiossen is they normally have, their reps who are chair side with you. It's very fast. So on average, in my hands, I could probably do an indirect sinus lift in about 7.5 minutes. But when you first start out, you maybe about a half an hour, maybe 40 minutes, if you're really being cautious. And it really gives you the confidence and predictability so that you can treat more of these patients. So these are just some comments from some of my colleagues. It's very easy to learn, very predictable, minimal trauma, again, because of the design of the drill. And what's great about this? If you're unsure at any point in time, just inject water, right? Add water and then see, are you having a lift? Do you have a lift or not? And I'll tell you how to get that, how to know that. So it's gentle, it's even pressure. So what happens, you get a nice even lift. You can control the volume. So I can control how much I want to lift versus with the Densa and these other contraptions, you really can't. So if I want more of a lift, let's say it's a wider sinus as opposed to a narrower sinus. Again, I'm talking medially and laterally. Then again, you might want more of a lift. It's very helpful even when you're doing lateral. You can do a crestal first, get some of the membrane off, and then again, go back in and do a lateral. You can confirm the lift. So what'll happen is as we place saline and we have a good seal, as we pull back, we should see some nice bleeding in that line. And again, I think we have a video showing that. But if you have perforations, you'll probably see it with bubbles. Again, it alerts you to your next surgical step. And I'll show you some videos that kind of really tell you, with Valsuva or just have the patient breathing, whether you perforate it or not. Even if you have partial access, so let's say you have a sloped area and you're performing a sinus lift, you can use this, and let's say you have one area that's accessed. Again, you can add some water, lift that area, and then take your drill one more step. So again, you can go, this kit really can apply to any shape or orientation of the sinus floor. So again, as I mentioned, we've got 3 stages in total, which I've just talked about. These are the components. So let's just go through the kit. We've got the drilling components. Okay, we've got the hydraulic pressure tool, and then we have the bone grafting components. And again, these are all included in the kits. And I love the new kit as well. Has not only the regular standard length drills, but also has longer drills. Again, in case you have that resorbed ridge and it's hard to get around, like a 2.5, for example, they have longer drills so that the head of your handpiece doesn't hit the adjacent tooth. So you'll notice here, there's an initial guide drill. It's very sharp, so that's like your initial point. Again, you'll notice all of these have, let me just see here if I can get my pointer, and I hope you guys will be able to see it. Maybe not, that's okay. So either way, you'll notice that they all have these like stoppers, and those stoppers actually fit onto the drills. They're like sleeves. So you'll see that every drill has that. The guide drill has it, the twist drill has it, and the CAS drill has it as well. So your first would be your initial puncture. Your second would be your twist drill, just to open it up a little bit more. And then your CAS drills, again, we're going to use those incrementally to enlarge the osteotomy first. Okay, so you enlarge it first, and then you start advancing 1 millimeter at a time towards the floor of the sinus. You have a depth gauge, so at every single step, you can check to see whether you are through the floor in any orientation. Okay, so the first one is the guide drill. Again, we just connect it normally to a 2 millimeter stopper. Sometimes I'll use something a little bit, maybe a 3, and if we have a higher ridge. And again, it's about 1200 RPM. Standard Hiossen drills are used at around 1000 RPM, right? So for those Hiossen users, you know that. The twist drill operates pretty much the exact same way. except, and I should have changed this in the slides, we want to stay away 2 millimeters, not 1 millimeter, 2 millimeters from the floor of the sinus. Okay, so 2 millimeters away is where you're gonna, so if you measure 5, your twist drill will go down to 2. At this point now, we're gonna use our CAS drills, and our CAS drills are those non-end cutting drills. They have wonderful flutes that actually, when you use them, you actually will collect the bone in the flutes. What I like to do, it also collects bone at the tip. So I like to actually leave the bone at the tip of my drill. I don't take that off. And then I go back into the osteotomy again. And I'll talk about that. So those are used at a lower setting, generally a 400 to a 600 RPM. And again, this is not like a marriage where you're sitting inside the site and, you know, for 5 hours, okay? You're a one-night stand here, all right? You're basically in and out and you're gone, all right? I hope that didn't offend anybody, but I apologize in advance. So basically, you don't want to sit there touching your drill, touching the membrane, you know, if that's where you're at, now you've advanced. Again, that could lead to higher perforation. So the fourth portion are the stoppers. So each stopper, it starts at 2 and it goes all the way down to 12. Okay, and again, you know, if you're at 10 or 11 at that point, you can place your implant, in my opinion. They're very easy to use, and they're all laser marked as well, which is very important, as are the drills. So everything is very visible and color coded as well. So the depth gauge allows you to measure. It has a little lip on it, and I've seen some doctors, they start poking inside the osteotomy. What you want to do is you just want to lay it up against the side of one wall, okay, and you'll have a stopper on it, right? And you just slide it up and you're feeling that little ledge. So if this is, you know, let's say this is the sinus membrane, you're feeling this little ledge that goes over that tells you that you perforated through the cortical floor. Okay, so that's something that you should use after every single drill once you start advancing the drills. Okay, the hydraulic pressure lifting tool, again, is designed to fit into the tip, you know, to fit into the osteotomy you've created from the CAS drills, and then get an adequate seal. And this is what's important. You have to get an adequate seal for this to work. Otherwise, you may think there's no, you know, you've got leakage or air bubbles, but in fact, you're not sealed properly and you're picking up air between the osteotomy and the hydraulic lifter. So this is where, when you place it, normally I like to use my fingers, but you can use a hemostat and then just really push it up against there. And then I have my assistant watching to make sure there's no water leaking, okay? Generally, we fill this up to a 3 cc syringe, sterile saline, and we inject about a half a cc and then pull back a quarter. Inject another half cc, pull back a quarter. How much do you inject based on bone? It doesn't, there's no rule of thumb, okay? My advice would be do a minimum of 1.5 cc's. That'll be enough to give you a good 3 to 5 millimeter lift. Sometimes I'll put a full 2.5 cc's in there. The more, the better, in my opinion. And initially we came out with very conservative, when they first came out with very conservative numbers. And as they realized it was better to detach the membrane more so that we can get more osteoinductive potential from the surrounding area, because that's how the bone forms in the sinus. So this is an example of a case where, again, we get a nice lift, we inject the saline, and I leave it in and I pull it out. So I pull my hydraulic lifter out and I tell the patient to breathe in and out. And I want them to breathe out the saline. You'll notice there's no air bubbles. Okay, you can nicely see the saline moving in and out, and that tells me I have a successful lift. And that's what you will see 99.9% of the time if you use the kit properly, okay? You don't rush things. There are also bone grafting tools, and they also come with stoppers. So the bone carrier has, in general, you'll see the bone condenser fits into the bone carrier, and then it stops. So it'll only maximum stick out there maybe about 1 millimeter from the tip of that. So you don't have a risk of perforating. The bone spreader has now been removed, so we don't use it. But this is basically what it looks like. So we add bone or charge we add some bone to the line, and then we start injecting it. What I find is I like to add a little bit of saline in there to basically help facilitate the packing so it doesn't get clogged in the head. Okay, and you'll notice that that little bone, the bone condenser, the tip of it will only go about 1 millimeter past the tip of the bone carrier head. So there's no risk of going right into the sinus with that. Okay, so again, they have a 1.1 and a 1.4 millimeter end. The bone carrier heads come in both sizes. I believe standard size, I think, is a 3.1, but again, you can ask the reps, they can correct me if I was wrong. Okay, so those are generally the components. So now let's go through an example. right? Let's go through an actual case example of how we're going to use this in real life. And this is a case, this case residual bone height that you're seeing right here post CT was 1.5 millimeters. Okay, that was 1.5 millimeters of bone that was there before. And that I added 3 cc's of volume, and we added a 1.5 cc of bone in this case. Okay, so it's pretty amazing at what you can get with this kit. And I've taken a lot of CBCTs post-op. I don't have a time to share all of them with you, but some say, oh, it doesn't work. Well, come into my office, I'll show you about 20 post-op CBCTs that all show the exact same thing, which is a nice lift like this. So let's say you're starting out and you find a case in it, you measure from the CT. On the CT, it says 6 millimeters, which we probably know there's going to be 8, okay, or 7.5. But let's say it says 6 or 7 millimeters, okay? So what's going to be your starting point here? Your starting point is going to be 4 millimeters, okay? So we're first going to take our initial lance drill. We're just going to go a couple of millimeters right through the cortical plate, just to give us so we're not sliding around, right? Second step, we're going to take our twist drill. Okay, and these are, again, our twist drill. We can use it at 1200 RPM like normal. This says, you can slow it down at this point if you want. It doesn't really matter. And then we're putting in, again, a 4 millimeter stopper. Okay, so we're now going and staying 2 millimeters away from the floor of our sinus. As we start doing that, okay, we now follow the next step. The next drill in the system is going to be the 3.1. And everything, I don't know if you can see this on the bottom, but the kit itself has in green a fixture 4.0. Now remember, let me make this clear. This kit is not just designed for the Hiossen system. Okay, this kit is a sinus lift kit. So it doesn't matter what implant system you're placing. This kit is used for, you're placing Nobel, who cares? You're placing Astra, it doesn't matter. It will design an osteotomy based on a fixture diameter that you want, right? Or you want. So it'll say in green here, fixture 4.0, and then it has a 2.8 drill and a 3.1 drill, okay? So this to me is like the soft bone protocol and then my regular bone protocol. But you'll still notice a 3.1 is about 0.9 millimeters smaller than a 4 millimeter implant. So all of these drills are under prepping the osteotomy quite a bit. But the way I use this kit is the first set of drills under the fixture. So let's say it says fixture 4.0. That's, if it's really soft bone, that's the drill that I'm using. So in some cases, I'm just using one drill. Okay, but now remember, we're dealing with the posterior maxilla here. Most of the time, we want to be placing for biomechanics at least a 4.5. I like a 5 millimeter implant. So I'm taking this normally up to a 4.5 or a 5 millimeter. So they have, if you'll notice here on the lower left, it's a little bit hard to see. I probably should enlarge this, but the fixture 4.0, it's in green. Then it's a fixture 4.5, which is in blue. And then a fixture 5.0, which is in red. And then what you do is it comes with a chart and it tells you, okay, these are the steps that you're going to use based on the fixture you place. And you just follow the steps like doing guided surgery. Okay, so now what we're doing is we're picking up our 3.1 drill, okay, which is the next drill, because let's say we want to place a 5 millimeter implant here, okay, so we're working up through the drills. And we're drilling, okay, but we're staying still a millimeter away from the osteotomy. Okay, sorry, I think I might have skipped a step here. Okay, so we're staying always a millimeter away. All right, so here's my 3.1, and I'm still at 4 millimeters. Okay, I haven't advanced anything yet. Now I'm at 3.6. Okay, and I still haven't advanced anything. So you're just enlarging things to 4.0, 4 millimeters, right, the depth. And now we start taking it 1 millimeter at a time. Okay, so whatever your last drill is, and the chart will tell you, okay, if you're placing a 4.5 and we're using the 3.6, let's call it as our last drill, okay? So really we've just used 2 drills here. It's very quick, okay? Then now that last drill, which is our 3.6, we're now, instead of staying 4 millimeters, we're now gonna advance to 5. And then we're gonna advance to 6, and we're hopefully gonna expect that at 6 millimeters, we feel some drop. Okay, and the trick here is to look at your CT. Look at your CT and see how corticated that floor is. If it's super corticated, then you should be able to feel up like a really nice drop. Okay, but sometimes it's not as corticated, so you may not get that feeling. I hope that makes sense, okay? So now let's say we use a 6. Okay, we use our 6 and now we're like, oh my God, I perforated the sinus, oh my God. So don't freak out, everything's fine. you're going to use your depth gauge. Now, if the last drill you used is at 6, what I tell doctors is to pick up a 7mm stopper and put it on your depth probe. Because if you put it at 6, you're really only going to go to where you've drilled. But I want to feel a little bit beyond that, right? So I always use the 7 in that case, and I slide it along the palatal wall slowly. Okay, and I'm feeling if there's a ledge there. Then I'm sliding it along the buccal wall. Most of the time, in many cases, you'll kind of go through on the buccal first, right? So remember I showed you that slope that we have. So again, we're just feeling. Now let's say it hasn't gone through. Okay, everything just kind of feels really dense. Or, okay, well, let's say we're worried. Add some saline. If you start pushing and you just get this force, then you know you're not through anything, right? Okay, so then now let's put on the 7. Okay, same drill, just now we put our 7 stopper. Now remember that 7 stopper was on our depth probe, so we just take it from there and we put it on this one, and now we go 1 more millimeter. And now we're through. This is what the drill is going to look like. It's gonna have all this beautiful bone at the tip and on the sides. I actually keep that bone on the drill, okay? Because again, that just gives me another level of safety. Now if it comes off, it's okay. But again, when you're using these drills, it's a one-night stand, right? It's an in, out, and that's it. It's not like let's hang around inside there while it's rotating, right, for hours, okay? So now we went to 7, and now we put an 8mm stopper on our depth probe to check to see whether we're through again. And now we can feel a little ledge, okay? You can feel like a little drop, okay? You'll feel that little drop. And so now the drilling is complete, okay? And if you can't feel that ledge all the way around 360, then at this point you can add some saline, which I'm gonna show you how to do. And then you can take your drill 1 more stopper up, right? So the last stopper we used was 7 on the drill. It was 8 on the probe. So we're just gonna take that 8 off the probe and put it on the drill and go 1 more deeper. Okay, and I hope that makes sense. But again, those people who have questions, you're welcome to write them in the chat, and then I'm gonna go through the questions at the end of this as well. Okay, so all right. So this is what we're using. All right, a quick tip when you're using this is number 1, first fill the syringe with saline, then link up the hose to your syringe, all right? With the hydraulic tip, keep it dipped in saline. So, okay, so the Hiossen kit, most kids come with like a tray, almost a sterile tray where you can keep some saline. So we're gonna put that hydraulic lifter, that green tip, in saline, so it's completely submersed. We're gonna remove all of the saline from the syringe, and then we're gonna fill it right back up again. And that's a quick and easy way to make sure there's no air bubbles, okay? So we fill it right up to 3mm, and now we make sure that it's engaged, all right? And it's sealed well. My assistant laser focused. Sometimes we'll even put a suction on it so I can hear, if I can hear some saline expelling through the osteotomy, then I know I don't have a good seal. And we're gonna add a bit, maybe half a cc, and then we're gonna pull back. We're gonna add a bit, okay? And then we're gonna pull back. And you'll notice in the line is tinted with a bit of red. There's no air bubbles inside of that, okay? It's just red. And that's basically when you detach the membrane, you normally get bleeding, okay? Because there's a blood supply there. So that's what you wanna see, all right? And then you add more and you add more, okay? This says in a single case defect, half to 1 cc. I would recommend doing a minimum of 1.5, but you can go up to 3 cc's all the way. Now, do you leave all of that saline in the sinus? You don't have to. You can remove all of it minus a half cc. I actually like to leave at least a good 1 or 2 cc's, and then I quickly remove it, and I have the patient breathe in and out so I can see them, and they'll push the saline out themselves. So again, here's another example. I quickly remove, you can see me rushing with the camera because I quickly removed it. There's saline still in there, and I tell Jeff, okay, breathe in, breathe out, right? So breathe in, breathe out, breathe in, breathe out, and you should be able to see that nice movement of the saline, okay? And there shouldn't be any air bubbles. Again, if there's air bubbles, it doesn't necessarily mean there is a perforation, okay? But there could be a perforation, all right? And that's where the crestal sinus, that's where doing an indirect is a bit more challenging, all right? But one of the errors that many people make with this kit, and I'll take you back to the drilling, is that when they're using this drill, They're not going perpendicular to the ridge, okay? So they're coming at an angle, and what's happening is the tip of the drill is hitting the membrane, and that's where you can have a risk of perforation as well. So it's very important to keep your drills nice and straight while you're going through the osteotomy, okay? The second verification code, okay, is going to be Ottawa, all right? So if you guys can make note of that for those of you who are wanting the CEs, okay, Ottawa. So now we're getting to our bone grafting. At this point, the saline is lifted, and now we're gonna add some bone. Okay, so there's some general ideas here. For me, my mom always told me, Azim, don't waste stuff, all right? So if I open up, what I like about something like a rhabdos is, you know, like a cortical cancellous mix, or getting a 1 cc product is that it comes in 2 half cc's. So oftentimes I will use half a cc for many cases. But if I need to go and use the 1 cc, you could use the 1 cc as well. What grafting material do you need to use? Well, I can tell you right now, do you need bone is the first question you need to ask you. Do you need to graft is the question, right? So let's look at the systematic analysis, review and meta-analysis. The new sinus lifting book, I forget what it's called. It's like a textbook. I can get you guys a name. It was published last year. And it's kind of like the guru on sinus lifting. Basically showed, number one, that in most cases you don't need bone at all right? There's no difference between adding bone and not adding bone in bone formation, all right? Let me make that clear. Here's another study, systematic review, showing that those non-grafted sinus elevation sites were characterized by new bone, okay? So what is bone for, all right? What is bone for? Bone is only to maintain the space, right? That's what you're using bone for. So if you feel like you need to maintain the space to keep the membrane detached, because otherwise it's going to fall back down, then you need to have bone grafting in that area. Okay, and I'll talk a little bit about that, it's coming up. But the grafting material doesn't matter. My advice would be get a powder, don't use cortical cancellous chips, because again, chips can perforate next to a membrane. Novabone is getting some pretty good reviews from some doctors, but I haven't used it myself. Okay, but again, a powder is really important. And again, Hiossen sells the Shuros or the Raptor, you know, I forget what the other one was called, but you can get these products, okay? But remember one thing in mind, okay? And it took me a while to figure this out. Sinus bone formation, sinus lifting is just about membrane separation. So if you have a narrow sinus, and I'm talking narrow from a medial to a lateral. So if you take a cross section and you look at the sinus and it's narrow, we'll say less than 10 millimeters, let's say, okay, so centimeter, or even up to 12 millimeters. Then if you're lifting your sinus, okay, and your implant goes in the same day, then the implant is going to keep the sinus membrane detached, right? It's going to keep the sinus there. So the bone laterally will fill in on its own without any bone. Okay, but if you have a wide sinus and you place your implant and you lift and you place your implant, what's going to happen is by hydrostatic pressure, the sinus floor is going to suck back down around the implant. So this is where you need bone. You need bone to maintain that membrane separation where it is. Okay, I personally still like to add bone in some cases because I like to have bone around the apex of my implant as well. Okay, so here's an example of a narrow sinus. Okay, so that's a narrow sinus. So probably if we lifted that and we placed our implant, we may not need to add any bone at all. And this is where the decision-making process comes in, whereby you say, oh, you know, I might see some air bubbles, you know, maybe, you know, I have a decent lift. I only need 2 millimeters or 3 millimeters. Should I add bone or should I not? What's the pros and cons, right? And for narrow sinus, in many cases, I don't even add any bone. I might just put a PRF or you know, nothing. All right, but for a wide sinus like this, you'll see the sinus is very wide. You will need something to maintain detachment of the floor of the sinus. So I hope that makes sense. For those of you who are doing PRF, it's very helpful to have PRF to be able to help seal any perforations if that does happen. So now what we do is we use the bone carrier, okay? We add the bone, all right? And then we go ahead, so there's the bone added, all right? You can see here, here's a double lift that I performed. You can do double sites as well. And then basically we place the implants. I call this one a 2-hump camel. I don't know if you guys can see it. There's the 2 humps. Okay, and there's the 2 osteotomies. All right. And then we place our implant. And always my recommendation is placing a healing abutment. Okay, you should be getting good stability if you're using a good thread, you know, like a Hiossen implant. All right, and a cover screw only if you get, let's say, 10 newtons or less, maybe 15 newtons or less. Okay, so these are the kit protocols. These are the procedures. And again, these are the steps. So you'll see here that if you're placing a 4.5 millimeter implant, you know, you go from your twist drill to your 2.8 to your 3.3. So that's just literally three drills, right? Same thing with a 5.0. It's no more than 3 drills and you're done, which is why it can take 7.5 to 8 minutes once you start doing this a lot. Okay, so we have about maybe 5 to 7 minutes. I just like to go through some quick case examples, and I'm going to kind of breeze through these. But this is a case that you'd probably see on an average, right? Hopefully you have about 7-8 millimeters of residual bone. So we're measuring the residual bone. We're taking a guide pin. You can still take a guide pin. Okay, you can take a guide pin actually with the CAS drill if you want, and tie some floss on it too to see where you're at in relation to the floor of the sinus. And then this is just the exact same video. All of these videos, and I posted a lot of cases on Facebook. You can see they all look the damn same. All right, they look cool as hell, but they all look the same, which is a patient breathing in and out. All right, so once we do that, you know, we put I put a little bit of PRF. If you're using sticky bone, it's going to be a bit tougher because it might clog the hole, so just be careful. Oftentimes I will add some bone and then take the IPRF and then inject it into the hole so it can coagulate once I've packed the bone in there. Again, that's a whole nother discussion. But you place your implant, here's some PRF membranes, and we just suture. Okay, so that's a pretty slam dunk case, 8 millimeters. A case where you have a bit less bone, so this is 7 millimeters on one side, and on the left side, there's only maybe about 4 or 5 millimeters. So same thing, a nice crestal incision. All right, you want to go a little bit more palatal because you don't want your stoppers to hit the palatal tissue and give you a false sense of how deep you've gone. And this is another way people perforate, is you're a little gun shy. You go maybe, you know, you go to 4, you think you've gone to 5, but you haven't because you're hitting tissue or you're just gun shy. And now you've taken a jump from 4 to 6. You've literally drilled 2 millimeters right through. So that's very, very important. You need to make sure your drills are to depth and they're perpendicular to the bone. All right, so this case we grafted on the buccal. You can see the lift and that bone that's at the apex. And then that's the site after. This is the right side where there was a bit, I guess this is a premolar, couple premolars that were missing. Okay, so again, we did the lift and then we added some bone on the buccal because there was also a buccal defect. So I would bill as a buccal GBR, like an actual guided bone regeneration, and a sinus lift. You could kind of incorporate the two together. But you can, you know, we'll talk about fees at the end. So this is a case, you know, where again, the 2.6 had to be removed. So we just grafted this, you know, socket preservation. I don't do a lot of that, but this is one of those cases. And we have some adequate bone to use. And now what we're doing is we're going ahead and we are performing our crestal sinus lift, again, using increments, checking to make sure we have no perforations, and then going ahead and placing our implant. Okay, and you can see again at the apex, that nice amount of bone volume that we have. Here's a more, you know, an SA4 case. Basically, an SA4 just means there's not a lot of bone. So SA1 means there's more bone. SA2 is like, you know, but again, that's neither here nor there. So we've now added, you know, we've preserved the ridge on this case because this case was severely compromised. I mean, I couldn't even do an immediate here, right? So you can see the CT is pretty bad. So what we've done is we've socket preserved this case. We've taken a CBCT about 4 months post-op, and that's what it looks like. That's the plan. And you'll see the sinus floor is not even here, right? So I've gone ahead, done my lift using the CAS-kit. I put a little bit of PRF first. Then I packed in my bone, which is also mixed with PRF. And then I placed my implant in the optimal position. Okay. And then we've sutured that up. And that's just what it looks like. Again, same picture, just this is the 1/6 region. And you can actually see the membrane there, right? What I like about less residual bone is actually I can see the membrane. I can actually see if there's a perforation versus a longer channel, right? It's harder to see down. So that's the before and that's the after, and that's pretty damn good, right? I mean, that's what you'll get fairly consistently with the CAS-kit. All right, so this case we let heal and then we did the restorative. It's not a restorative course, so I will skip. This is a screw retained crown, but you can see again, this is all done in a period of 4 months. So 3.5 months of healing and 4 months the patient had a crown. All right. So the double lift, I know I'm probably gonna get questions about that. Can you do a double lift? Yes, the 2-hump camel, I call it. You'll see here, here's one hump and the other hump posteriorly. And once you lift, I like to lift one site first the mesial site first, because by gravity it'll lift distally, and then I do the second site. What happens is you have to plug the first hole with your finger, because you won't get a proper lift because it'll just leak through. So you can see this patient breathing, you can see both holes kind of moving at the same time because we've lifted both sites. And then I'll go ahead and I'll actually place an implant, but the implant's in that area, and that's what it looks like. So probably could have added more saline to get more to that medial wall, but I think this is acceptable. When you're looking at locator cases, don't forget about the posterior maxillary bone and the tuberosity, because oftentimes that's the only place they have bone. So again, you'll see here, one side I did a crestal sinus lift on the upper right with adding no bone, and the left side I added bone. You can see that nice, just to kind of get a post-op CT to see how much bone generation we get. I haven't gotten it yet. But again, look, by getting a proper AP spread, like look at the spread for what this patient's gonna have, probably better than what most people get anyways. And it's because we wanted to avoid doing a lateral sinus lift, and that's where the crestal sinus lift can really help out. Okay, the last case is just an immediate molar. Again, the way that I teach it is an immediate molar with a crestal sinus lift through the tooth. Okay, and so what happens is, again, we section it, I expose the interseptal bone, I then use the crestal kit to perform the lift because I want to keep the roots there. Number one, I don't want perforations. Number two, I want to maintain my hydraulic pressure, right? And so then, so that's what it looks like when the patient starts breathing through. Again, a pretty cool shot with the patient breathing, and you can see the sinus floor come, and now it goes, and comes and goes. So after that, we then remove the roots, and then we place our implant. Okay, and then it's done. So I think there's the post-op CBCT. All right, I think I have maybe a couple more minutes. So again, with the CAS-kit, this is what you were doing before. And it's a nice car, classic, whatever, but wouldn't you rather have one of these? Seriously, welcome to the CAS-kit. All right, so post-op is pretty much the same. You tell the patient, I typically have these patients go on antibiotics if I know I'm adding significant, a decent amount of bone, because you're doing some sinus lifting, just amoxicillin. You can do a pre-op loading dose. I tell them a combination of advil. Most of these patients will tell you they didn't even know they had a sinus lift done. Okay, no blowing their nose, smoking, drinking through a straw. Again, if they notice any granules or anything like that, they need to let us know. And again, if they get any excessive swelling or pain or bleeding or discharge, I've never, ever had that problem, ever, when using the CAS-kit. This is the code that you would all use. This is, again, in Ontario. So for those of you who are out in BC or across Canada, look up your code, but it's a indirect. And we would be using, if you're using Allo-graft, if you're using something like BioOS, then you would put the xenograft code in as well. Okay. What's great about Hiossen is they always have offers for their attendees. So this is the regular CAS-kit. I have 2 of those kits. I also have 2 of the CAS-kit Plus, which has the additional drills, the longer drills, which sometimes I've had to use for some cases because, again, things get in the way. So they have a promo here that you can ask the reps about. That's available if you mention that you were on the webinar. Okay, so as I mentioned, I am part of a network, or I have founded a network, so we're always open to new members. It's ODI Network. You can check out the Facebook page and Instagram page, and you feel free to email me if you have any questions about the webinar. It's Dr. Sheikh at livedentalsurgery.com. Also, I'd like to acknowledge Hisham and his group. They run some wonderful webinars as well that I've been a part of on implant surgeries. We just had one with Dr. Stephen Diana, so reach out to them. It's DTA Academy. And lastly, of course, we have more of these AI short webinar series coming up, and that would be aiceducation.ca, e-education, and there's a lot of great courses on that as well. So a lot of options for us who are, want to get our hashtag mind off COVID kind of thing. All right. So what we're going to do is we're going to go through some questions, and then I will give my, well, actually, you know what? Let me just give you guys the last, well, you know what? Let's just go through the questions. And then what I can do is I can give the last, what do you call it? The last code, the verification code. they have oh, hello? Can you guys hear me okay? Can you guys hear me okay? Yes? Okay. Yeah, I don't know. Something, for some reason, somebody cut me out. So, okay. So let's just go through some of these questions. As I mentioned, there was one question about how would you use CAD-kit with fully guided, and they do have something called the one CAS-kit. Okay, and the one CAS-kit is basically guided, using those drills guided. Let's put it that way. So again, I would just advise you to talk to your reps, but there is a version for guided surgery, okay, called the one CAS-kit. Can I get a copy of the presentation? Unfortunately, we don't release the presentation because I do use these and there are patient-specific data, so unfortunately we can't do that. But I believe that they're going to be posting this as a webinar recorded. Again, we can check with the Hiossen team on that. Maybe somebody can make a comment in there for those who were asking about that. How do you do with angled floors? Well, with angled floors, all we do is we still use the drills like this, except what's going to happen? We're going to probably penetrate the sinus floor. Remember, I don't use perforate. Okay, we're not perforating. We're penetrating the sinus floor in one area, not another. So we're not going 360 degrees around. So when I feel like I've gone through a little bit, or I can feel that with the depth probe, or I'm unsure, I'll add some saline and then I'll take it up 1 more millimeter. And I'll go incrementally like that, okay? Does PRF play any role in sinus lifts? Not really. I mean, it gives us peace of mind if there's a perforation. The PRF sticks really nicely to that area. And then, of course, if we're doing larger grafting cases and we're worried about a perforation, if we're adding bone and we can coagulate that bone, there's less chance of that bone getting back through the perforation and then plugging up the ostium. So PRF, I believe, is valuable, but it's not absolutely mandatory. When do you enlarge the size of the osteotomy? After you drop the first burr. So again, this is when you follow the steps, which I mentioned, which is the initial, guide drill, the little piercing drill that goes through the cortex, then the twist drill, then the CAS drill. You just follow the steps with the CAS drills until you come to the size implant that you want to use. And that's it. You just follow those steps. Okay. Can you repeat what you said regarding having your CAS drill being inaccurate based on palatal tissues? So what I was saying is if you do a mid-crestal incision, so it's mid-crestal, okay, and you haven't reflected your palatal tissue enough out of the way, which if you listen to my 12 steps of surgery, you would know that reflection is step 4, okay, all right, but you need to reflect and then retract that tissue out of the way. Otherwise, when you use your drill with the stopper will hit the palatal tissue. And it'll give you a false sense of how deep you've actually gone because you haven't gone right to the bone. So that's why I was saying it's very important to lift the palatal tissue out of the way or make an incision that's even a bit more palatal, okay? So that your drill, when you drill and your stopper is touching the bone, that's what you want, okay? Does the patient feel anything when the saline is injected? If you do, so does the patient feel anything when saline is injected? The answer is depends on your local. If you do a high apical infiltration, okay, there's a chance that they will feel that separation. I recommend doing a PSA, posterior superior alveolar block, and then I don't get any, then the patient typically won't feel because there can be innervation that will supply, especially the lateral wall of the sinus. So you want to make sure that you have good local, okay? And what's my protocol for perforation? I just pretend I didn't see it. No, I'm just kidding. So it depends. If you have a minimum of, let's call it 7 millimeters of bone. And actually the studies show if you have a minimum of 5 to 6 millimeters of residual bone, you can just go ahead and place a 7 or 8.5 millimeter implant. Now bone won't form, but the sinus floor will heal properly. Now if you have the implant sticking 2+ millimeters into the sinus, then that's where you're gonna have a problem. So it really depends on the case. How much how much lift did I really need? If I didn't need a lot, you just plug it with a sterile object and move on with the rest of your life. Okay, don't worry too much about closing back up and then going back in. But you need to have that certain amount of residual bone, which is why when you first start doing these cases, you want to choose the cases where you have a good amount or a good adequate amount of bone, residual bone, so that even if you get a perforation, you can still place the implant. Okay. So how would I treat perforations in cases of vertical sinus lift? How would I treat perforations in cases of vertical sinus lift? So I think that's the same question, which is basically, how do I treat a perforation? And generally I'll plug in some PRF, and I definitely will not put bone. Okay, if there's a perforation, you suspect perforation, don't go packing bone inside that area. Either put the implant in if you have enough residual bone, and this is where having a good stock of implants as well comes into place. You should have 7, 8.5, 10. I mean, I have a full stock, but you should be prepared. That's in preparation, okay? What if you don't get a good seal with hydraulic lift? Well, you have to figure out, and that's a good question. If you don't, then it could mean that, and the only reason why you shouldn't is if the channel is too small, okay? So if you're dealing with a residual ridge that's very, very short, or an immediate molar situation where again, it might be hitting the roots, but you should be able to get a good hydraulic lift all the time, a seal. There shouldn't really be a reason, unless you've over-prepared the site, or again, you're not angling it properly, you're not holding it properly, but that shouldn't really happen in cases that you first start doing, okay? When you get to less residual bone, the trick that I use is I keep the hole smaller, because if the hole is smaller, I will get what? I'll get more pressure. If the hole is bigger, I'll get less pressure. So again, that's a more advanced technique, okay? Can you explain once again, why do mesial first when you're doing multiple sites? Number one, when you're doing a multiple site, the mesial site normally has more bone, okay? So there's less risk of perforating in that area. There will be a deeper channel in that area, so you will get more pressure in that area. Also, so that's the first one. The second is the patient is sitting backwards, right? So as you push saline, where is it going to travel? It's going to travel distally. So you'll probably get some distal lift as you're doing your mesial lift anyways, all right? Because it's just going with gravity. So this is why I like to start on the mesial site where there's more bone first. Okay, so is it possible to place implants on the same day as sinus lifts in most cases? Yes. If you have good stability and you have good residual bone, then there should be no reason why you're not placing the implant the same day, because the implant will help to maintain that membrane separation as well, right? So you should have a good system. You're using the Hiossen system, you'll get really good stability. Okay. When do I prefer xenograft or allograft? I just use whatever's the cheapest. Okay. It doesn't matter what you use. Xenograft looks nicer on an x-ray, but I mean, again, I just showed you don't really need bone in many cases you don't. You can, if it's a narrow sinus and your implant's going to hold a membrane up, then you don't even need bone. Okay. So again, I will typically routinely use an allograft. But again, I'll use a xenograft if I really want to see what's going on, because it appears better on an x-ray. What's my opinion about the guided CAS-kit versus the regular CAS? I mean, many of the doctors whom I train through the basic training program like guided surgery. It gives you the confidence. So this is where the guided CAS-kit or the one CAS-kit will help you give confidence with the stopper system. Everything's already built in, okay? You still do so again, that's another course, but I don't do a lot of guided crestal sinus. I actually have not done a case yet. I feel very comfortable with the kit myself, okay? So Hassan asked, if you don't do PRF and you perforated the membrane, what is your protocol? So again, what I would do is the first step is don't perforate, okay? Plan your case, take enough time, don't check hygiene, don't do stupid things, and you won't perforate, okay? I'm not trying to be facetious here, but it can happen to all of us. So what you wanna do is you wanna assess how much residual bone you have. And if you have enough, which I would say more than 5 to 6 millimeters, 6 millimeters and above, then I would just place my implant. Again, I might be planning to place a 4.5 there. Maybe I'm gonna go with a 5, because again, I want more surface area So maybe I'll go a 5 or even a wide body, like a 6mm implant, to get more surface area and engage the width as opposed to get more height. Okay, but the protocol generally is don't add bone. I put a PRF in there and I'll plug it with the implant if I feel comfortable that there's enough residual bone. What do you do when, so Muhammad asked, what do you do when you have some sinusitis? So I'm not sure how much time we have. Dinesh, can you maybe just give me a pro quo here in the messages? Like, do I just keep going through these questions, or are we cut off at 4 o'clock? I'm gonna wait for Dinesh to respond here, because I still have some questions coming through here. Johnny, he said, Johnny, we can stop here. Oh, okay, so we can stop here, okay. Okay, guys, so I think what we're gonna do is there are a lot of additional questions. Maybe Johnny or Dinesh can advise on how best to answer those questions, and I'd be happy to respond to those questions at a later. Oh, do you want me to please respond? Okay, so please respond to the questions. Yes, okay, please respond. Oh, I gotta give you guys the last code too. So for those of you who are listening, I know it's a little bit disoriented here. So the last code is actually Hiossen. Okay, the last code is Hiossen. All right, so for those of you who needed the last code, wow, there's 200 of you, nice. So let's keep responding to the questions, and then Dinesh, what I'm gonna do is, if you wanna just maybe text me on WhatsApp and let me know when I need to stop, then I'd be happy to do that, okay? So let's just keep going here. Just gonna jump through these, okay. Okay, so if you don't, okay, so what do you do when you have some sinusitis? Okay, if there's any form of sinusitis or chronic sinusitis or any type of pathology, then you need to have that assessed by an MD, period. Okay, so I would not recommend performing any type of sinus surgery on a patient that has chronic sinusitis. All right, so if they have mucositis, that's okay, that just means a thicker membrane, but sinusitis, it needs to be resolved. Okay. So can everybody hear me okay? I hope, yeah, okay, good. What was the codes that we used again? Again, hopefully this will be recorded so you can go back to that, all right then? What torque do you use for the drills? So the torques are just preset on whatever the machine is. So I don't know what that torque exactly is, but it's just preset. But it's more the RPM that's important. And the RPM is generally for the CAS drills is 400 to 600 RPM, okay? What's the amount of bone ratio we put compared to saline amount? Don't worry about that. Don't confuse yourself. Just put the bone, like wet the bone, make sure the bone is wet, and then just start packing it. If you need to add more saline, it doesn't matter. Again, everybody gets hung up over how much bone, depending on how much lift. Just whatever you opened, use it. So half a cc will be pretty good. You know, if you want to put the whole cc, if that's what you have, put it all in, right? And you can always take a PA. You've seen some cases there where I took a PA after I added the bone, okay? When you mentioned the ledge, you said to check on the buccal and lingual. What about mesial and distal? So yes, Nicole, that's a good question. I meant, you know, I generally check the buccal and the palatal, but you would also just kind of walk it around and just kind of feel very, very gently. Okay, very gently, not aggressively, but yes, you want to check the entire osteotomy. So let me correct myself. What to do when you feel, okay, so we got till 4:10. So what to do when you face the septum? When you face the septum, you treat it just like a sloped sinus. You go with your CAS drill, okay, and then you add some water, and then you advance, again, another millimeter, and you might still be in that septum, right? And then you add some more water, and then you advance again, and you add some more water. And what you're trying to do is you're trying to lift any areas that get exposed in that actual osteotomy, okay? How do you deal with the bony septum? I just keep preparing into that area. Just keep preparing with your CAS drill, okay? And then take it up a millimeter at a time. If there's a small perforation, can you still use a non-PRF membrane to seal it? Yeah, you could put some collagen, but again, these things are only what we're just putting those in to make ourselves feel better, right? What is it really gonna do? Who knows, right? Because again, you can't see. So, I mean, if you want, you can put it in, or you can just put the implant in, okay? What is your preferred bone material? I mentioned that. It depends. It really depends on if I really need to see. If it's a large graft, you maybe do an allo-xeno mix. You use whatever you want and get a powder and get whatever's cheapest, okay? Because bone, it doesn't matter. It doesn't matter what you put in the sinus. Everybody knows that. In case of a mucus retention cyst or thickened membrane, any modifications needed? So for thick membrane, no modifications are needed. It'll actually make your life a lot easier when you're doing sinus lifting. For mucus retention cyst, you need to see where that cyst is located. If it's on the medial wall and you're not going to be drilling in that area, then you don't need to worry about it, okay? But because we're using hydraulic pressure, even if it is in the way, all right, you could technically use the CAS-kit, but my advice would be not to do that. All right, it's going to make things more challenging. I prefer to do a lateral approach in those cases, and then I'll actually pop the cyst, and then I'll just repair the membrane either with a suture or a collagen membrane. Because the risk is you perforate that, and now you have mucus material around the base of your implant. It's like having an apical lesion now exposed to your implant, and the implant's gonna fail, as would the graft, okay? Do you suction out the saline before bone injection? No, I do not. Nothing that you can leave saline inside the area. I just have the patient breathe it in and out. Okay, so you can leave the saline. You don't need to remove all the saline before you do that. Is there any bruising or dark eye? No. The patient doesn't know they had sinus lifting done. They just see a bill for $1,200, okay, or $800, whatever you want to charge for the procedure, okay? And they are very thankful and they're very happy to pay that, by the way, because the other option is a lateral approach, right? Or seeing a specialist who is going to charge more to do stuff anyways, when in essence, you can do this for them. Okay, again, taking it step by step. Will the residual saline be absorbed? Yes. In my full day, I have about 40 cases, and I show a case where I've done one lift. I'm doing 2 sites. I've done one lift. Then I placed the bone in the implant, and I did another lift, placed the bone in the implant, and there was some saline in that area. And then after 4 months, it just was all radiopaque. Okay, so it'll resorb. Are there sinuses that you won't lift? Yes, if there's chronic sinusitis or the patient has had a history of sinus-related issues, then I would take those cases on very cautiously. Or for some reason there's an ostium issue, so I don't normally in our field of view scans get the ostium, but if we do refer them to a place that has a 15 by 15 or 12 by 12 and there's an issue with blockage or there's an issue, then yes, again, you want to take on the cases that you feel comfortable doing. During a lateral window, if you hit the artery, what is the protocol? Pray? No, I'm just kidding. You have to know how to manage it. And so we'll use damp gauze to soak up the bleeding. We'll try to perform the lift as quickly as possible, but without tearing. So again, these are, questions. These are more for like lateral stuff. Is there a more economical alternative to the little clear tube? It's not about economics, really. I mean, the clear tube is reusable and sterilizable, so economically, it doesn't really matter. Okay. What's a minimum height of bone the CAS-kit is suitable for? So my advice would be to start off with a residual bone height of 7 to 8 millimeters, okay? But if you're asking what we can do, I showed you a case, if you caught it, where there was 1.5 millimeters of residual bone, and I actually lifted it 20 millimeters. So we got 2 centimeters of height. And that was the case that I first showed where there was 1 millimeter or so of bone. I don't know if you remember that CT with the nice drape. So you can do some pretty crazy things with the CAS, absolutely. But I would not recommend that when you first start out, okay? Otherwise you will have problems. What is the shortest residual bone you could use? 1 millimeter is what I've done it with, okay? But you won't. What's a contraindication? The only contraindication is if you can't get hydraulic pressure. So if you can't get pressure or hydraulic pressure for some reason, and normally it's because you can't seat it properly, and normally, again, that's with an immediate molar where the roots are getting in the way or there's holes somewhere else, or it's leaking out somewhere else, then you can't, I mean, it's not contraindicated, you just won't get a lift, okay? If you're doing 2 adjacent sinus lifts, do you place the mesial implant first? No. So I like to do both lifts at the same time, and then I place the bone and then the implants. But as I mentioned, in the longer, when we have more time, like a 2-3 hour venue, then I show you both scenarios where you can do it that way. Okay, but again, there's a little bit more complexity to that. If it's only one implant is placed without bone to hold the membrane, is the risk for perforation increased? So by just placing the implant, you're not going to have the risk of tearing the membrane, right? If the implant is there and the sinus membrane sits against it, again, I wouldn't be worried about tearing or anything like that. It would happen more when you're doing your osteotomy. Okay. Can you place a collagen membrane? We answered that. In an immediate molar with a periapical lesion, any suggestions regarding how to deal with that? Yes, but it's not for this course. That's my immediate full day course where I go through how to use the CAS-kit and manage the apical lesion and still place the implant and graft and do sinus lift. So that's a bit above this. Okay, so I think currently right now, Dinesh mentioned that we do have to stop at 4:10. So I would like to thank everybody for attending. I hope that it was beneficial. And hopefully if there's demand and you would like a little bit more of an advanced or maybe just a Q&A on something like this with the CAS-kit, I have a lot of videos and a lot of cases, and maybe you can request that from the Hiossen team and they can kind of sort that out. But please record the verification codes. Okay, and then make sure that you have those and you can present those to the Hiossen team. But it was my pleasure being with all of you, and I look forward to hopefully seeing you guys on many more. As I mentioned, a lot of great webinars, and I look forward to again hearing from you all. Okay, thank you and have a wonderful day. Pleasure.